clear.
Good afternoon, Mr. Chairman.
Russell.
No, I don't think so.
Appreciate the opportunity to come before you to share thoughts about the rural hospitals. My name is Jimmy Lewis. I'm CEO of Hometown Health, and we represent about 50 or so hospitals in Georgia and about 15 in Florida. And we get involved in all aspects of trying to keep a hospital open and viable. I want to start my comments out by saying thank you very much as a committee for what you have been about all the years and the times that we brought these subjects to you before. It's been, had you not been on board with us, we would be in much worse trouble than we are today. I've just had an opportunity today to share with the Rural Caucus what I'm about to share with you, and thank you. This may be a bit redundant, and I apologize for that, but I think it's important to hear that, Mr. Chairman. Many conversations you and I've had about this subject. So let me start off first by saying within the budget that we have, we want to say from a rural hospital standpoint, thank you, and more thank you for the fact that that we've got money budgeted this year without cuts, and money budgeted this year without cuts is extremely important in that we're already thinly starved, if you will, from a cash standpoint. That is very critical not only for the ongoing Medicaid book of business, but not the Medicaid expansion, but the expansion of Medicaid that has occurred through Woodwork. And to be able to fund that and that not come out of Medicaid cuts is critical. And so to the committee, to the governor's office, the OPB, we can't say thank you enough about that, especially then in covering what the Woodwork effect is about. So that's extremely important, and again, we thank you. The next part of it is within the budget now for your consideration, and it's been in there, I guess, since about '05, but it's been a different means by which it got worked, and that is private dish. And there is about $14 million in the budget for private dish, and that's critical for those private hospitals by a federal designation that gives them the opportunity to have a disproportionate share payment. It's important to have it, but it's important to know also that the disproportionate share payments have continued to shrink. They've continued to shrink by redevelopment of the formula within the state of Georgia when CMS called our hands on how we had the formula developed, so we had to do that, and that has impacted rural hospitals significantly. Then we face, out of the ACA, the probable loss of DISH altogether, which is a $400 million or so program, and that can occur in the next year or so, depending upon who one believes, whether it's 2017 or whatever the year, but we can face that. That'll be a real problem. To put into perspective what kind of problem that is, the department, and we work very, very closely with the department, I can't say thank you enough to them as well, pertaining to cash flow for rural hospitals. They have broken the distribution of the DISH up into two payments, a fall payment and a spring payment. And the fall payment is normally designated for an end of December payment to the hospitals who would get that. The problem is that we are in such a cash flow starved position that rural hospitals literally can't wait for that DISH. And in the fall session just ended, we prevailed upon, called upon, and asked and did receive help from the department in getting DISH early to a number of hospitals just to make payroll. Now, to put into perspective what that means, we, from a hometown standpoint, over the last 6 months, have been involved with what I'll call payroll interventions. And a payroll intervention is when we get a call on a Friday night from a hospital that says, I don't have any cash. And that's serious for us because we need to make payroll on Tuesday, and we don't think a remit's going to have any cash on Monday. So we're trying to determine either A, how to get cash or close the hospital. And we were able to move some things around with CMOs who have been wonderfully helpful in these situations in DCH. But the long and the short of it is, we're in a stage now where as soon as DISH is identified in a calculation, we need to get as much of that to the hospital as we can. They did good in December, and now we're back right after December, and we got the second distribution that's due in May, and we come to you to prevail for as much as it's to be approved. We need to get as much of that cash distributed also for the purpose of payroll. I'm working with, I guess, 4 or 5 right now who have the request in to get that cash moved over to them as quickly as we can, and understand that it's tied directly to the approval of the budget, but necessarily we need that cash for those to make payroll. So that problem is for real, but I guess it's important to take the time to address the real elephant in the room, if that's suitable, and that is while we're extremely thankful for all the situations relative to the reimbursements due to the Floridas, we still have a couple that are ongoing for us. And the first one that's ongoing for us is the fact that we continue to be paid less than cost. I went back and looked at how long we've been paid less than cost, and we go back to the year 2000. If I run the numbers on that, we're running about a $200 to $250 million a year underpayment against Medicaid. If we look at that over a 10 or 15 year period, what we can find is we're about a $3 billion underpayment into our system. I was reminded of that this week when I was in a hospital helping them do some strategic planning, and they were trying to determine if the hospital could survive based on their population and their revenue. When we got into the discussion, the first order of business was we've got to have $16 million in order to cover an expense that we know is here. Well, what is the expense? Well, we need $6 million to cover payables that are booked and we got to get out of, and we need $9 million to cover equipment. And so what does that mean? Essentially what they were doing was they were needing that money to go bond to cover unfunded depreciation over this period of time. We have an industry that because of this is worn out. The industry simply, very simply stated, is worn out. We somehow have to figure out as a state how to address that, and we ask you, if you can, to carry that message up into the budgetary process, because this is not going away. Again, we've got 15 years of this underpayment, and it's absolutely critical. The other part is we're running whatever it is, 10%, 9%, 8% of self-pay and unfunded, and we've got to deal with that. And that amount of money is just absolutely huge and beyond belief. And when we tie it all together, we're in a situation where we have an unusual phenomenon occurring, and that unusual phenomenon occurring is that we're in the last stage of funding evolution, where the last stage is that when there ain't no other source to fund, the last one is the county. And we are now seeing a cost shift into county requests all over the state. All over North Georgia, we're seeing strange things happen with bonding. We're seeing strange things where counties are having to assume $38 million worth of bonds. We got another one in North Georgia, Hutchinson, that's closing because of these kinds of situations. We got another one that's about to close or downsize up in North Georgia, and down in your neck of the woods, we've got all sorts of problems. I say that to say that if we don't figure out a way to address this in some form or fashion, we're going to lose the whole industry. Well, we have a stabilization committee that has been cited or designated to figure out how to solve the problems with rural hospitals. And we've done an excellent job of finding ways to improve the process of healthcare. The problem is the efficiency gains can no way offset what we've got in terms of these underpayments and self-pays and the things that were associated with it. So I say all that to say, to take advantage of the fact to say thank you, and thank you, and thank you. And then I say, at the same time we say thank you from a DISH funding standpoint, we ask you to help us, and the department has been most gracious in helping us with expedite certain DISH funding to make payroll and the issues that we need to do that. And then however we deal with this issue of underpayment, somewhere along the line we've got to get it on the table. So with that, sir, I appreciate the opportunity to share with you.
Thank you. We have a question. Representative Gardner has a question for you.
I want to say, first of all, thank you for all you're doing to try to keep the rural hospitals functioning in those communities. I mean, no matter where we live, we know we need those rural hospitals to continue to thrive.
Thank you. Yes.
But would you remind me why the DISH payments were discontinued, why they have been going down?
The DISH payments have been going down because we went through a process of redesigning the formula, I guess, about 5 or 6 years ago, because it was brought to our attention that there was maybe be some disproportionality in the disproportionality. So we went through that and we set up a transition period of about 2 or 3 years. We worked through it. The end result is those hospitals that by formula were more disproportionate started then to get, if you will, their share of the money. Unfortunately, it impacted many of the rural hospitals who saw their DISH payments dropping, in some cases pretty significantly, as much as 50%. So that's part of that.
Well, if you think about the Affordable Care Act as a puzzle with several pieces, I mean, why was the decision made to reduce the DISH payments?
In their case, the decision was made to reduce the DISH payment in order to have offset it by other reimbursement funding mechanisms.
So the bottom line funding mechanism is what?
They were going to figure out a way to pay for Medicaid in some other form or fashion, or Medicare, whatever the case may be.
At 100% of federal dollars.
Yes.
Is that an agenda for you? Do you think it would be important for?
Well, clearly we have a lot of hospitals that need a lot of cash. However, that's over my pay grade.
Mine too.
Representative Hawkins has a question.
Did I hear you correctly? You're saying you're losing money on Medicaid patients?
Oh yeah, have been for.
So if we do more Medicaid patients, what happens?
Well, it's
You
kind
lose
of
more money?
like if we lose a little bit on a watermelon, and we're selling 100 watermelons, and now we go up to 500 watermelons. Well, we're gonna make any more money? No. So it's
That's sort of the way I hear it.
it is a matter if you can distribute overhead a little bit, but there's no way with these kind of underpayments that we can distribute overhead to offset this underpayment.
Part of your problem with dish funding is the federal government's actually reducing the dish funding through the ACA.
Well, yeah, there's 2 or 3 different things happening in the dish. We're having a formula reduction in dish, then we're having a transitional downgrade in dish, and then we're going to be looking at a total elimination of dish.
Right.
So, you know, it's kind of like torture by 1,000 different drops or something.
You're surrounded by Indians, aren't you?
Something like that, yes.
Well, it's obvious that we're going to have a discussion another day about all of this, so we won't try to solve that today. But I'll just make this statement. I think that we are going to have to realize one of these days that we're going to have to pay providers, doesn't matter who the provider is, a reasonable fee for what they do. That's kind of a bottom line. Now, where we're going to get the money to do that is the big question, but I think the point is well made, and we'll solve this other problem another day. Thank you.